stress to you guys is that this is free points. So you can't really guess your way out of this. You either know it or you don't. And that's why it's important to really be on top of this before test day. So going over what a cast is, they're little cylindrical structures. They form in the nephron. This is really the key thing. And they precipitate into the urine where we can look at them via a microscope. If you're taking step 1, you might need to know that they're made from TAM horsefall protein. So just a reminder, this is going to go into the ureters and then be peed out. So most casts form here in the tubules. And if you haven't seen this diagram in a while, I thought it would be good to bring it back. So we'll come back to this summary, but essentially what we have is we have hyaline casts, muddy brown casts, white blood cell casts, fatty casts, waxy casts, and RBC casts. Just know all these. And this is a picture of what they all look like. We're going to break these down one by one. So the most important thing to know is that if you have a test question and they describe that there are hyaline casts found in the urine, you need to know that this is a normal finding. This is just caused from those TAM horsefall proteins. And this is a normal finding. Let's go over some high yield associations. If you think muddy brown casts, I want you to think about acute tubular necrosis. This is what they look like. And so what this is this is epithelial cells that have died. And so whenever you see this, you need to know this is indication of death in the tubule. And what causes that is something called acute tubular necrosis. And couple things to know. This is the most common cause of AKI in hospitalized patients. You're going to have possibly low blood pressure causing this, sepsis, aminoglycoside antibiotics. And really, when we start thinking about those high yield level 2 concepts, we need to imagine something like myoglobin. Maybe they give you a patient who's in rhabdomyolysis. They've just, ran a marathon. That myoglobin is going to hit the kidney and kill it. One thing to note is that because ATN, this is an intrinsic insult. And so that compromises the ability of the tubule to reabsorb salt. And so a value we care about is called FeNA. And so when you see ATN, I want you to think FeNA greater than 2. And why that's important is, let's say someone has a pre-renal AKI from hypotension. That is not going to cause acute tubular necrosis until it gets worse. And that's the big idea here. When you see this, I want you to think about red blood cell cast. And this is caused by glomerulonephritis. So just integrating here, because that's how we get more questions right. IgA nephropathy, that's one of the biggest causes of glomerulonephritis. And for that, you give an ACE inhibitor. If you have a kid who had strep throat and you're thinking about APGN, you actually just restrict salt and water. And that most of the times treats this. So you don't need ACE inhibitors in a kid. Don't forget about lupus nephritis. This is an important cause of glomerulonephritis that's tested on level 2. And the reason why is that, they can give you a confusing patient about someone who has a rash, joint pain, and you think, okay, they're going to ask me an easy lupus question, but instead they ask you about lupus nephritis. And just know for real life, up to 1/2 of lupus patients have a chance of having some sort of kidney involvement at some point. And so this is the one that you treat with cyclophosphamide, which is a chemotherapy. It's an immunosuppressant. This is one of those where you either know it or you don't. And so if you see these Maltese cross signs, you can Google that if you don't know what that is. What these are made of is these are lipids. And so when you think about, normal physiology, lipids can't get into the kidney, right? We don't just pee fat out all the time, unless you have something called nephrotic syndrome. And so just integrating here, in nephrotic syndrome, you're going to pee out more than 3.5 I think this is milligrams, but essentially more than 3.5 grams of salt per day. And you're going to get periorbital edema, and the urine won't be red in nephrotic syndrome because it's, there's no RBC casts. I want to teach you a little bit about nephrotic syndrome and how it looks like at the nephron level. And so this is a normal nephron. We see lots of little cells. We don't see a bunch of hyaline. We don't see a bunch of sclerosis or necrosis. This is a normal nephron. What I want you to look at here is some of the nephrons are normal. They look exactly like this. And then some of the nephrons, they're very hyaline, so they're very pink. And so even within those nephrons that are affected, there's some normal areas. And so what I want you to keep in mind is that when only some of the glomeruli are affected, and of the ones affected, only some parts of the glomerulus are effective, this is called focal segmental. And we'll get into what that means in a second. But this one, if we compare it here, there's no normal regions. Everything is affected. And so we call this membranous. And just getting into some integration here, two of the biggest causes of nephrotic syndrome are FSGS, which we talked about, and membranous nephropathy. Another thing they like doing is asking you epidemiology questions. So if they're a black patient, they probably are this one. If they're Caucasian, they're probably this one. That's one of those little epidemiology things you need to remember for both level 1 and level 2. Now, don't freak out on me here, but I taught you these 3 findings. The important thing is sometimes we need to look at the electron microscopy to know what's going on. And so if we see a spike in dome appearance, and so what that is we have spikes, which is made up of basement membrane, and then we have the dome, which is, these are immune deposits. And so our membranous, aka affecting all parts of the nephron equally, our membranous nephropathy shows spike in dome appearance. And this is going to be treated both with steroids and cyclophosphamide. Now, the other one that we talked about, where we had some normal regions and some sclerotic regions, remember we were calling this FSGS. So we treat that with steroids. And then the third one, I've just posted a picture of a normal nephron. And if you remember, in children, the most common cause of nephrotic syndrome is minimal change disease. And minimal change means exactly what you would have guessed. It means you have a normal kidney until you do the EM, the electron microscopy. And just like with FSGS, we see podocyte effacement. And so I've just given you the 3 most common causes of nephrotic syndrome. You likely won't be asked anything beyond this. This is a cast that's very important. So it looks pretty similar to the red blood cell cast, but it's white. And so this is obviously a white blood cell cast. The most important thing it's seen in is acute interstitial nephritis. And so you're going to have someone who was either taking a lot of NSAIDs, they'll tell you something about arthritis, or let's say they recently were treated for strep, and they'll try to confuse you. They'll try to make you think about, glomerulonephritis. But if they give you this buzzword right here, eosinophils, and a rash, you need to be thinking about acute interstitial nephritis. However, this can also just be seen in UTIs that have ascended. So if they give you a picture of the acute interstitial nephritis, it's all I've seen on questions is that it's described as being on the trunk, and it's kind of maculopapular, which obviously it looks a little more confluent here, but you won't have to diagnose it just on this. Just be able to integrate it with the white blood cell casts and the eosinophils. So just summarizing, hyaline casts are normal, muddy brown casts are acute tubular necrosis, and you need to be able to think about why it could have happened. So the most common cause is from a prerenal AKI that progresses and causes ischemia, but you can also have maybe contrast dye or cisplatin. Acute interstitial nephritis, that's super high yield. It's usually caused by NSAIDs, but also penicillin antibiotics. If you see fatty casts, and this was, that Maltese cross sign, that's caused by nephrotic syndrome. And recall that nephrotic syndrome interrupts the basement membrane. One thing we didn't talk about, because I think it's pretty low yield, is a waxy cast. And so if you think of, a hyaline cast that sits around all day, and, we picture like a clock just ticking, it becomes waxy. And this is seen when you have slow kidney function. And so the reason for that is chronic kidney disease. And the last one is RBC cast. The thing about RBC cast, they'll typically ask you something about what caused it. One other thing to know is that bladder cancer does not cause cast because it's post-nephron. This is a picture putting all of them together. And with that, I think we're done for today. Thank you, guys.